Hi, everyone. Welcome back. Hope you've had a good morning. It was a really fruitful discussion in the plenaries and the concurrent sessions. Thank you to all our moderators and panelists who made those so terrific, and for all of the great questions and comments from those of you in the audience. And of course, I'm going to plug how great the networking session was. It was definitely as enjoyable as the first, and I hope that some of you got to take advantage of that. So we're moving into the closing, the final sessions of our two-day symposium. It's been a terrific time, lots of great ideas, lots of great discussion. We will start off with a keynote from Dr. Rochelle Walensky, who's the director of the Centers for Disease Control and Prevention, and follow that with a plenary where we'll look ahead into 2022 and really try and take a look at the global health landscape for the new year and see how best we can engage as a community to move all of the things that we talked about today forward. If you have questions or comments, please feel free to put them into the chat box, and we'd also love to know where you're joining us from. So please feel free to announce yourself, who you work for, where you're calling in or dialing in, I guess, in the virtual word from. It would be great to see that and find out who's in the audience. So without further ado, I'm pleased to introduce Dr. Walensky, the 19th Director of the Center for Disease Control and Prevention, and the 9th Administrator of the Agency for Toxic Substances and Disease Registry. Prior to joining CDC, Dr. Walensky served as Chief of the Division of Infectious Diseases at Massachusetts General Hospital from 2017 to 2020, and Professor of Medicine at Harvard Medical School from 2012 to 2020. She's been serving on the front line of the COVID-19 pandemic and has conducted research on vaccine delivery and strategies to reach underserved communities. Dr. Walensky is recognized internationally for her work to improve HIV screening and care in South Africa, and nationally recognized for motivating health policy and informing clinical trial design and evaluation in a variety of settings. Dr. Walensky had hoped to be here live with us today, but due to a last-minute scheduling conflict, she's opted to provide us with a pre-recorded keynote. So I'm going to ask that we bring up that recording and hear what she has to say.
I cannot be with you live for this really important event. The next time we meet, I do hope it will be in person. It's an honor to speak with you, my colleagues around the world, in raising awareness and catalyzing action around important global health issues. Those of you working one-on-one and collectively, raising your voices, making yourselves heard, advocating for our shared priorities in global health. I was asked to speak with you today to share my reflections on how we can be sure that global health security narrative includes our global goals for health equity and the strengthening of global health systems. Global health security, improving and protecting the health of everyone around the world, requires that we work together, all of us, civil society, local communities and federal governments, non-governmental organizations, and the private sector, that we be broadly engaged, and that as a group, we represent diverse points of view. That depth and breadth of participation is what is so clearly represented by the Global Health Council, whose members advocate for the continued need to invest in global health and build the bipartisan support that is critical for life-saving efforts around the world. The Council's Global Health Policy Roundtables, letters to policymakers, communication materials, and events like this symposium are essential in establishing, sustaining, and strengthening the core public health capabilities that every country and the world needs. The Council, its members, and all of you challenge us to think more creatively and strategically about the many ongoing global threats posed by perennial public health challenges, such as HIV, malaria, and TB, while sharing the lessons from our current pandemic so that we will never be in this position again. Who knows how many millions of lives have been saved and will be saved through your efforts? In his 2008 article in the journal Health Policy and Planning, William Aldis highlighted the ambiguity and confusion surrounding the term health security, emphasizing the need for the global public health community to work towards a common understanding, definition, and acceptance of the term. While we have been using the term global health security for more than a decade, there is still ambiguity and confusion about what it means. Is it activities required, both proactive and reactive, to minimize the danger and impact of acute public health events that endanger people's health across geographic regions and international boundaries, as WHO defines it? Is it the existence of strong and resilient public health systems that can prevent, detect, and respond to infectious disease threats wherever they occur in the world, as we define it at CDC? Or is it an unnecessarily us versus them approach to global health that perpetuates unequal power dynamics without adequately addressing health equity and social determinants of health? As noted in the Global Health Council white paper, From Security to Solidarity, when we hear the word security, we often associate it with national security. If we think of health security purely in terms of national security, we risk adopting a short-term emergency response mindset in global health, which runs counter to the long-term commitment needed for strengthening public health systems. Yet we recognize that framing global health security in terms of national security has been important to engage the partners who are necessary in the efforts to develop whole of government and whole of society approaches, to build systems, and to develop necessary political support. We need the support of those partners now more than ever. Framing global health security in terms of national security maintains engagement of these much-needed partners, and when done correctly, health security is national security for every country. True health security calls for broad engagement of partners and a strong emphasis on health equity. The Council's From Security to Solidarity white paper suggests a new lens, human security, stating that this new lens could bring a different perspective and urgency to issues that have been regrettably partisan in the past, with political ideologies hindering health policy actions on key challenges like healthcare, climate change, migration, and protectionism, as well as other global health threats that have been neglected for far too long. Human security implies freedom from danger, fear, violence, hunger, or lack of health care. And in fact, the United Nations defines human security as an approach to identify and address widespread and cross-cutting challenges to the survival, livelihood, and dignity of people. So when we consider global health security or national security within the frame of human security, when we shift the focus, we prioritize health and equity as a basic human right. As many of you know, from my first day on the job at CDC, I have made it clear that health equity must be at the core of our public health actions, both here in the United States and around the world. Global health security, human security, requires equity in public health across the globe. We know that no community, district, or province within a nation will be truly safe and healthy until all are. We also know that no nation, including the United States, can be truly safe until all nations have the core public health capabilities and the health systems in place to protect the most marginalized in our societies. If it did nothing else, the COVID-19 pandemic globally brought into sharp focus the critical need to build a workforce and a system that is trusted, the importance of building strong, equitable public health infrastructure both domestically and globally, with a deliberate focus on addressing systemic inequities and establishing a public health workforce that reflects the diversity of the communities it serves, has never been clearer. It requires that the community believe their government is working toward the public good. It requires trusted community health workers who walk the dirt paths past leaking standpipes and front step hair salons, armed with a mental roster of those in their community who need a visit and perhaps some counseling to take an action that will lead to improved health. We have seen healthcare systems grind to a halt during disease outbreaks. One has only to look at Ebola, Zika, and now COVID-19 to see that. We must not separate global health security from the need for a well-functioning, equitable health system. A successful response to any outbreak depends on many things, but without access to quality health care, a disease can spread unseen and unchecked. Key public health functions that contribute the most towards health systems strengthening and that have the greatest impact on improving the public's health include the core public capabilities of a skilled and capable workforce, strong public health laboratory networks, surveillance capacity, and critical emergency operations. True global health security requires strong health systems and long-term comprehensive strengthening of these health system components is the foundation of equity in global health, or human security. Vaccination infrastructure is an example of how strong routine health infrastructure is critical for global health security. We know that widespread vaccination is our best protection against COVID-19. Every country needs a functioning national vaccine delivery system with nationwide reach, effective distribution, access for marginalized populations, adequate cold chain, and ongoing quality control in order to respond to disease threats quickly and efficiently, not only to protect against COVID-19, but also for the routine immunizations that will protect against polio, malaria, and TB. Strong health systems and strong emergency preparedness capacities reinforce one another. Investments in core public health capability minimize vulnerability to acute public health events that endanger the collective health of populations, including across geographic boundaries, providing global health security and human security. In that 2008 article in the journal Health Policy and Planning I mentioned earlier, Aldis suggested that the global public health community work towards a common definition of the term global health security. I think perhaps we need to make sure that health equity and strong public health systems are tightly woven into the concept of global health security. The United States and the world have responded to disease emergencies since long before CDC was established. It is just that the stakes are now higher. Globalization and the increased interconnectivity of the world have raised the level of risk for everyone across every sector. We are certainly feeling this today, right now, as we all fight to respond to the COVID-19 pandemic. For CDC, our mission is to work with our partners to prevent, detect, and respond to public health threats domestically and abroad. This is the case regardless of what term we use. Our work, and yours, does not change depending on the terminology that we use. Our goal should be to use terms that are well understood and that capture the critically important work that we all do. CDC and the CDC-like institutions of the world house the technical expertise, train the public health workforce, strengthen the laboratory and disease monitoring systems, and establish the emergency response capacity to improve quality of life and reduce the risk of death and disease for everyone by strengthening the public health system. We must talk about global health security in a way that emphasizes health and equity as essential and that recognizes the value of partnership among nations in building resilient public health systems to protect people everywhere. We will only achieve our goals by working together. In this, you have CDC and me as your partners in this work. Thank you to the Global Health Council for your continued leadership and for prompting thought-provoking conversations like this one. It has been an honor.
Wow, thank you, Dr. Walensky. That was a great speech. You hit on a lot of the things that we've talked about over the past 2 days. So it was almost like you were right here with us. You talked about trust, access, quality, investing in existing health systems, health workforce, diagnostics, laboratories. We have covered those in various ways across the past 2 days. So it's great to hear that CDC is on the same page. So now I would like to move to our closing plenary, and I am going to, in a minute, ask our panelists to be moved to the virtual stage. So this plenary, moving forward, global health advocacy in 2022, is, as you can tell, looking forward. And I think the challenge in any conference or meeting where so many ideas are raised, there's so much great discussion, is how do you sum all of that up and find a path to take action on some of the things that you've heard. So hopefully we're going to do some of that, not to place a tremendous burden on the panelists to walk us through every way to move on global health security and global health equity. But I do hope that we can look across the global health landscape for 2022 and get some insight from all of you about opportunities that are tangible and actionable that this global health community can really coalesce around in the coming year. And I have some questions queued up for the panel, but again, I'd encourage everyone to add your own questions into the chat, and we'll definitely take audience questions throughout and after we get through the moderated session. So let me tell everyone, though, who's here with us today. So first we have Tom Hart, Acting Chief Executive Officer at ONE. And Tom has been with ONE since 2003. Prior to serving as acting CEO, Tom was the North American Executive Director, leading a professional bipartisan team dedicated to proposing and passing government policies to fight disease, hunger, and poverty, mostly in Africa. And I do want to say that I am giving very truncated bios for these folks because what I received would have taken up the whole time because they're so esteemed and have so much experience. Dr. Jen Cates is Senior Vice President and Director of Global Health and HIV Policy at Kaiser Family Foundation, where she oversees policy analysis and research focused on the US government's role in global health and on the global and domestic HIV epidemics. We're also pleased to be joined by Julie Becker, Senior Vice President of Chemonics Global Health Division. Julie leads the division's strategy and growth and its work in health systems, strengthening HIV, malaria, and private sector engagement, among other areas. Dr. Angela Wakuya, did I say that right? You gave me the phonetics. Wakuya, okay. Wakuya, see, okay. There's something about that Ugandan Kenya that I always have a trouble with. She's the Senior Director of Health Equity and Rights at CARE. Dr. Wakuya is a Senior Policy and Program Administrative Leader with over 25 years of progressive experience in public health, program management, and fiscal monitoring, with a strong technical background in HIV/AIDS, malaria, TB, and other infectious disease etiology, epidemiology, prevention, and care services. And last but not least, Irene Koch is the head of the Department of Global Health at Save the Children US. She joined Save the Children in late July 2020 after more than 30 years with the US Agency for International Development. Ms. Koch has worked extensively with international partners, including serving as the chair of the Stop TB Partnership Coordinating Board and representing USAID on the board of Gavi, the Vaccine Alliance, for several years. Welcome, everyone. Thank you all for taking the time to be with us today. It's exciting to have you here and pick all of your brains to help this community move forward in 2022 on global health security and health equity. So I know you all haven't been able to join us for the full 2 days, but it's probably no surprise to you that many of the conversations were about resource needs and what kind of resources we have or need to get, how they're distributed, how they're expensed, who they go to, lots of things to unpack in there. So knowing that we can't do the work without the money, I'm going to dive into this question right away. And I'm going to kick this one first to you, Tom, But I would encourage others after Tom is finished, if there are additional things any of the panelists would like to say, I certainly welcome open debate and discussion, and please feel free to jump in. So Tom, let's talk about money and global health financing. Can you tell us about the need in 2022 and where is the money going to come from? And what are the moments for this community to engage in 2022 on resource mobilization?
Great. Love talking about money. the fuel in the engine. The fuel in the engine. So, I will try to provide a brief answer to the question. So, Administrator Power had a convening earlier this week where we learned that the money that has been available to USAID for COVID response is now completely tapped. And we know this is true across other elements of the US government. So there is a real need, an urgent need for the administration to request supplemental resources from the Congress. Many of us, including many of the groups on this panel and many others watching, have come together around a bold ask to the administration so that they will then ask the Hill on the order of 17 billion, maybe even greater than that, dollars in supplemental resources. The US has already provided about 18 toward the global COVID response, which is incredible, but much, much more is needed. And I should say in context that the United States actually is heads and shoulders above every other country in terms of its direct commitments of doses, of dollars, of partnership, of manufacturing. So I want to be super clear to my US government friends out there that we're really, really pleased with what they've done. But clearly more needs to be done. Other countries need to step up. There is a global need. There's what we hope the US will do and request from Congress. But there's obviously a global need, and we need other donors to step forward. The ACT Accelerator has identified a need of around 43 billion. I think it's around 48 billion overall from all sources needed to help reach that 70% vaccine coverage rate. And again, that's not even dealing with global health security, pandemic preparedness, and some of the longer term things, which I know are incredibly important. So our work is really cut out from us. Where are we going to get it? I actually think that the US Congress, perhaps even on a bipartisan basis, will support supplemental funding for the global COVID response. If we needed more evidence, Omicron has shown us that this virus will not respect borders and that there is no national only strategy. I sense a real receptivity to tackle this globally, along necessarily with other major donors and in partnership with poor countries themselves. So there are a number of opportunities to address this. One is President Biden's Global COVID Summit, which is sometime in early 2022. They have got to set a date rapidly so that other countries can plan and be part of this productively. But that is going to be a key moment for the donor community to come together and help make the contributions necessary. And then, of course, there's the G7 hosted by Germany and other international moments where the United States needs to set forward in a leadership capacity, but also to galvanize resources from others. Much more I could say, but I will pause there.
Thank you, Tom. Does anyone want to jump in here and say anything about the financing? Dr. Wakuya?
Yeah, sure. I'd love to jump in there. Really three things, at least from where we sit at CARE. One is that the US government needs to appropriate new funding and not utilize existing funding, which is a trend that we are seeing, that funds that are already appropriated is what they want to put forward. And that actually cuts other programs at the knee. And then the second thing is the funding for vaccines is coming at a rate at which we don't think, as Tom said, will meet the 70% herd immunity that we are wanting globally. And what is missing is that even if we provide the vaccines, that providing the funding for program delivery is what is missing. And that is what we call stomach to arm. Like once the vaccines reach the countries, there's inadequate funding to get the vaccine from the stomach at the airport to the arms of individuals. And that is where organizations such as Save the Children, CARE, Chemonics, and KFF, and also other local civil society organizations can really help national governments move that. Then lastly, we need to invest in community mobilization so that we can tackle vaccine hesitancy and increase vaccine confidence. There is inadequate funding that is going towards that critical piece, which allows communities to understand COVID-19, to understand vaccines, to combat disinformation and misinformation, much of which has been spread over social media and has gone ahead of all of us, all organizations, to the point that it's going to be very difficult to change the minds of people that vaccines are safe. Thank you.
Thank you. And Jen, go ahead.
Yeah, thank you so much. I want to add two comments. One is completely support. That the world is on fire, and I think what we're saying is how do we put this fire out? And it's very urgent. Fires spread and get worse. And at the same time, we have the existing global health programs that we all care about. And one thing I just want to, as an overlay, the economic impact on countries. We cannot forget that is something that, in the White House's global COVID response plan, it talks about helping countries recover from the economic hit. But that's a whole other level of challenge that I think we have to acknowledge and we'll be facing for years to come. And the second comment I wanted to make is about pandemic preparedness. So right now we're mostly focusing on the current fire, and it's very challenging to also keep in mind that we know there'll be new ones. And how do we prepare and adequately resource our country and other countries to be ready for that? Thanks.
Irene.
Yeah, sorry, we're going to completely blow
No,
here.
no, it's totally great. It's great.
Right. But I just want to build on a couple of the points and completely agree with what everybody said so far.
But we can't really hear you. I think you're cutting in.
Jen just talked about two things that are really important. That I just want to add. One of which is all of the other global things. This morning the number of COVID deaths was 5.3 million. 5.3 million children die every single year from causes, right? So as we really have to do that, the world's on fire, exactly as Jen said, and we have to do everything we can around COVID, but we can't ignore all of those other things that have been so fundamental and are so critically important, like child survival. And secondly, I also think we can't also lose sight, and as we look at the resources and press for resources, of the impact that COVID has had on livelihoods and the increased vulnerability of families, and we'll talk about equity later on, but so many families are in crisis and is leading to huge issues for not only kids, for adolescent girls, and increased hunger and malnutrition around the world.
Thanks. Julie, do you want to chime in or? Okay. So can I just take moderator's prerogative here? And one thing I love about this community is we are excellent at identifying the problem and lifting up the data about the problem. Can we talk a little bit more specifically, especially going into 2022? I mean, the issues that you raised around livelihoods, economies, and Tom, I've heard you say this before, and I agree that the US, as part of its leadership in this, has got to set a date. Right? Like, we've been pretty bad, and maybe it's because the world is on fire, but we've been pretty bad at lead time on many of these global moments so far in COVID. The first Biden summit was sort of a 1 week creation. And then we had the Blinken ministerial, and we had Powers, ministerial with her counterparts, all of which kind of came out of, not nowhere. Obviously, people were hard at work behind the scenes, but it makes it difficult for global health advocates, implementers, civil society, communities to really engage in these processes. So I would love to hear from the experts of really where are the opportunity, and how, if you want to, do you get more immersed in this and start to work either with your own national government or with the US government to really press on some of these issues? And Tom, I'm going to kick it to you to start because you brought up the summit.
I'm picking the short straw, which means I have no time to process your question. But no, so you're exactly right. The gatherings that have happened. First of all, let's just acknowledge that the first 18 months of the pandemic, there were no gatherings. Like, there wasn't a G7 meeting on the pandemic for the first 15 months, which is just unbelievable. So at least there are a few things happening. Mm-hmm. My minor suggestion is just to be polite, to send out the invite slightly ahead of time. When it really is shooting ourselves in the foot to provide leadership, but then to come in so late that people feel blindsided or feel like you don't even really care if they showed up or not. I know that is not what our government feels, but that is what is received when things are organized and announced so late. The Biden summit in early next year was billed as an opportunity, much like a global fund or Gavi replenishment. It will be an opportunity to gather everyone together to reach a common goal. A Gavi or global fund replenishment takes a year from the time the case for investment is put out and the pledging summit. Moving the billions of dollars through national governments across the world takes a long time. And while I am very bullish and supportive of what the president has set out to do, there is literally no time, and you've got the holidays in between. They have got to urgently set a date, set a fundraising target, and set some shares that will add up to the whole. And then we're going to need their diplomatic skills, into which advocacy and advocates like us and Global Health Council and everyone, so many who are listening to this, can then input our pressure. If we are simply shouting into the wind, you need to do more, you need to do more, it might have some effect, but I will tell you at the moment, it is not having much of an effect. We need to be able to tell France, here's your piece of the puzzle, here are all the arguments, and here's the outside pressure. And we need to do that across the G7, G20, and frankly, with many others, so that our advocacy has a framework into which it can have an impact. So I'll pause there, but I think that is what's so desperately needed.
I think that's true. And I think this goes back to Dr. Wakuya's earlier point about the new money, right? That we need this to be a pledging moment, not a commitment moment, and something new. And so I know you wanted to say something, Dr. Wakuya, so please go ahead.
Yes, just briefly, we need a Winston Churchill moment, and we've had them twice in the past. We had a Kofi Annan moment when he announced the Global Fund for AIDS, malaria, and TB. We need also a PEPFAR moment, which was a George W. Bush moment. So we need that from the Biden administration, a leadership moment that, as Tom says, set a target, set a date, get the money on the table.
Okay, anybody else wanna, Jen?
Yeah, I just add that one data point here. The public does seem to be on the side of this, which, this has been a very partisan, challenging time in our country for the last couple of years on a health issue. And yet on global health security and pandemic response, we've had a lot of good bipartisan support. But on this specifically, in our polling and other polling, when you put it to the public and give them the information that a U.S. leadership response will help, and that we have enough vaccines at home, that if we help vaccinate the world, it will prevent the risk of variants, and all of the arguments, they're not even arguments, they're facts. The public is very supportive of this, and that's even true by party. And in fact, Republicans go from not being supportive of the U.S. playing a leading role to the majority being supportive. So they get it. They're living through it, and there is support if that helps make the case. Thanks.
Yeah, that's great. I know Kaiser has some great polling data. Maybe we can share the link to that with the audience. I'm going to turn us from this question because I know we can talk about this for quite a bit. Still, actually, it's in the same vein. The pandemic preparedness, the pandemic response, the community engagement, all of that requires strong and resilient health systems. And I think COVID has shown us that we have not invested in health systems the way that we needed to. So Julie, as head of health systems at Chemonics, I'm going to turn to you and really just ask you a little bit about this. If you can, delve into, given our experience with COVID, how should donors focus their investments to ensure that we have strong health systems that both support global health security and also universal health coverage objectives, which we've heard a lot about over the past couple of days?
Thanks, Alicia. This is, I'm sure, something that's been discussed quite a bit for the last few days. And it's obvious that the global health community needs to think beyond emergency response to those long-term solutions to strengthen health systems and build their resilience. And as you mentioned, it's important for both pandemic preparedness and for reaching UHC. But strengthening cross-cutting functions of health systems like workforce development, supply chain, or leadership and governance may require investments that can't show those short-term results that donors are often looking for. So for example, donors may be reluctant to invest in pre-service training for health workers, even though it can have a long-term positive impact on workforce capacity and preparedness. So instead, programs often do multiple issue-specific in-service trainings. So we need to invest in coherent, comprehensive approaches to health system strengthening that reinforce those essential functions of the health system. I was recently in Senegal, where we're starting up a comprehensive project to strengthen government stewardship across all of the health areas and functions. But I realize that it's not often that donors are willing to work in such a holistic way. So my kudos to USAID Senegal for supporting this work. But in general, health systems investments have instead often been through disease or health issue specific funding programs like HIV or MCH, or they've been piecemeal on one aspect of the health system. But when programs compete for resources, it may be at the expense of some of these system functions. So for example, it might deplete the primary care workforce or create parallel supply chains for specific products that leave the healthcare supply chain weak overall. So while we need dedicated response to crises, when that emergency ends, all of those parallel functions need to be integrated. And to do that, health systems need to be strong and have the absorptive capacity. We've seen in the past, in response to other crises, when parallel systems are created, we see shiny HIV clinics standing next to dingy maternity wards, and we see well-functioning ARV supply chains bypassing dysfunctional overall health supply chains. But we have come a long way since then. And I think disease-specific programs are contributing to health systems more broadly in areas like HIV programs strengthening labs so that they can support other diagnosis for other infectious diseases, or integrated surveillance systems. So vertical funding, while not ideal, can work well if there's strong governance. And I wanted to mention quickly, there was, we had a session at ICASA earlier this week, and Dr. Agnès Binagwaho, the former Rwandan Minister of Health, was addressing how her government led the HIV response in a way that overcame those funding silos and allowed them to use HIV funding to strengthen the broader system. So they had an integrated vision and strong national policies and coordination. And with that, they were able to convince donors to spend HIV money on a cohesive health system, avoiding things like redundant supervision, reporting, procurement. And they were even able to use HIV funding to create pre-service training. So when it comes to advocacy, I think we do need to move beyond vertical funding toward health system integration. But the problem is that system strengthening is a little abstract, and it's much harder for some people to understand than diseases or mothers and babies. But I was thinking about it and wondering if COVID might be presenting us an opportunity for change. It seems that the pandemic is elevating the importance of health system strengthening because it's exposed the weaknesses of the health systems. And it seems that the whole world, including decision makers, is now understanding how these systemic weaknesses are causing countries to struggle to deliver COVID solutions while maintaining those essential programs. So I wonder, could COVID help us better communicate why strong health systems matter? This really may be an opportunity, an important opportunity to determine how to best parlay this opportunity into meaningful investments.
Thank you, Julie. I love that your health system strengthening is abstract. Everyone on the panel was like, yep. certainly is. So let's take one component that maybe is less abstract, and I would like to ask others if you want to chime in, particularly around workforce, because I think what we heard throughout the symposium is what you said, Julie, that really investing in existing health systems is key. Not just to get us through the crisis, but beyond the crisis. And also we heard from other panels how key that is to fostering health equity. So I think one of the components of that is around health workforce that maybe is a little more understandable for people. And I know, Dr. Wakuya, you probably have something to say about this, and Irene as well. So whoever wants to chime in first, please go ahead.
Not to say the same thing, but okay, I'll start. There's yeah, Julie, there's so much you put out there that we could again talk for hours on that, but maybe just about the pieces you asked, Alicia, on health workforce. I think COVID has shown us a number of things indeed, and it's certainly about the vulnerabilities of the health workforce and the need to protect health workforce as we go forward. We've also seen about the limit, the bandwidth and the number limitations, as we know, over and over and again across countries, including here in the U.S. Right, just not enough numbers to meet needs in a crisis like this. So those long-term investments in the health workforce are critically important. They have to happen on the donor side, but they also have to happen on the customer side, and they do. They never, ever meet the needs. But then there's, it gets also back to Julie's point about governance, right? Are there enough jobs for the numbers of midwives and nurses and others who come out of the training programs? And not always in many of the countries where this work. So it is that governance, it's putting the resources where they need to be and make the investments in the systems to keep those the healthcare workers employed. One other piece that I also, and this has come up in a lot of conversations, I think a number of us have been in around the workforce, and that's around the sort of the gender issues in health workforce. So particularly among community health workers, who are absolutely the backbone of so many health programs and absolutely of global health security. We can come back to that later if we have time. But it is about, who are often the women, and women who are not necessarily fully paid for the jobs that they do. So a lot of issues on there as well, but things that we know we can try to really address and push forward on. So let me stop there. Maybe Dr. Angela can pick up on that.
Please go ahead.
Sure thing. This is one of my areas of passion when it comes to health system strengthening. Frontline health workers. COVID-19 has shown us that because it affects the entire global population, there's nobody immune to it. It's a breathing disease. It's very infectious. And so we will all have to touch the health system at some point. And as Julie correctly said, health system strengthening is going to be very much the foundation of the response. And what does that mean? It means that a system cannot touch an individual to give them a vaccine all by itself. A building can't do that. A person has to do that. And that's why frontline health workers are absolutely critical to the response to health system strengthening. And that's the whole bandwidth, because frontline health workers include clinical and non-clinical, formal and informal, volunteers who are not paid, and then formal workers who are in the clinical system who are paid. And the majority of them, 70% of them, are women. And so there is a gender lens to the whole frontline health worker response, and governments need to make an investment in frontline health workers if we're going to make any headway with respect to COVID-19. And then the other piece that COVID-19 has taught us is that we need to digitalize as fast as possible, because 7 billion people in the world, if we're trying to reach herd immunity, are not going to be registered, tracked in terms of they've got the vaccine, come back for your second dose, come back for your booster shot. Let's know whether side effects have affected you. Let's look at complications from the vaccine or the disease itself. We're not going to be able to do this with pen and paper. we need to digitalize. And that's one thing that COVID-19 has shown us. And health system strengthening needs that piece in terms of digital technology, digital health, digitalization that makes things more efficient, and also that we can track and have dashboards to be able to know what we're doing. And then lastly, when it comes to health system strengthening, the logistics and supply chain management is going to be absolutely critical. And it comes back to your point, Julie, about HIV having shown us that we can strengthen the system. So COVID-19, in terms of it being a disease that can be tackled by a vaccine, will help us deal with childhood vaccination issues, for instance. And so with respect to a part of the health system strengthening that COVID-19 is leading us to deal with, is the fact that we need to get our logistics straight. We need to get our supply chains straight. We need to also get our policies and regulatory frameworks correct. Over.
Thank you. Can I actually kick this to Jen and Tom just for a second? Because I think, Julie, you made this really excellent point about leveraging the verticals. And I think PEPFAR and Global Fund have been such good examples. And I know, Jen and Tom, you've done such great work on that, not just in terms of the clinical health workers, but I'm also thinking about the diagnostics and this digital component that Dr. Wakuya mentioned. Do you see opportunities in 2022 with the change in leadership in PEPFAR? Hopefully we'll have a nominated coordinator to really kind of make strides on leveraging that system for some of these other issues that we've raised. I don't know, Jen, you want to take that first?
Sure, I'll start. Also on the digitization, I just want to support that. As someone whose own vaccine card in the United States is not digitally proper yet, I really support that. So on the question about, and someone put this in the chat, about using the vertical programs to build on health systems strengthening and healthcare workforce. We're doing some work to look at how much PEPFAR is actually contributing to pandemic preparedness activities and health system strengthening to get a better sense of that. And, not a big surprise, workforce is one of the biggest areas. A lot of the positive results that PEPFAR has had, it's not just because of ARV support, it's actually workforce, and a diverse workforce in many different ways, not just clinical workers. If we can we being the global community, identify that is an opportunity for much more marginal investment needed to build on that system. I don't think anyone thinks that creating a whole set of new systems and repeating a lot of what we have is the best use of our time and resources. So it's finding that where it already exists and building on it. There's a lot there. Same with the Global Fund. So I think a first step that's already underway is quantifying it and identifying it, but also being cognizant that it's delicate, not to take away from the existing work of those institutions. But yes, I think there's, PEPFAR has also put out a lot of data showing that it's been using its healthcare workers, its diagnostics, labs, equipment for the COVID response. And I actually participated in a webinar earlier this week where there were examples from 4 countries in which PEPFAR is actually vaccinating people with and at risk for HIV in those countries. So it can be done, it is being done, and I think it offers a lot of promise. Thanks.
Thanks. Anything you want to add, Tom?
Very little to add to the expertise that's already been offered here, other than to say I think there's a greater opportunity in the pandemic preparedness discussion and debate than there is in the current response. Mm-hmm. Of course, we should be leveraging the existing health infrastructure for the response. Of course, we should be doing the response sensitive to the long term. But I think intellectually, or maybe I should say politically, when you're preparing for the next unknown, you're building infrastructure that can deal with lots of different things. When you have a specific problem, malaria, HIV, COVID-19, politicians and others tend to think, all right, we're just going to tackle those things vertically. So I think the pandemic prep offers a more receptive political opportunity to make a difference there.
No, that's great. That's great to hear. And in that, I want to turn back to you, Dr. Wakuya, to talk a little bit more about communities, because I think we often talk about health workforce as part of a system and don't necessarily recognize that those people are part of the community that they're serving. And we've heard a lot of I don't want to say rhetoric because it's not empty, but a lot more conversation about meaningfully engaging communities as part of having a strong pandemic response and pandemic preparedness. But again, just like health system strengthening, engaging is kind of abstract, right? We haven't really drilled down into that. So I would love to hear from you. I know CARE does this all over the world. Like, how do you meaningfully engage communities in this conversation? And is there any lesson learned from other crises of how best to do that? Oh, you're still muted. Still muted.
Sorry about
There you
that.
go.
You always say you're not going to do it, and then you end up doing it, isn't it? So we can't speak about health workers without also or even the health system strengthening, without speaking about the communities that health system is trying to serve. We also recognize that health challenges such as the COVID-19 pandemic don't happen in a vacuum. Pandemics are infectious diseases. They come from one individual and go to another. They come from one community and go to another. As we've always said, with COVID-19, if no one is safe until everybody is safe. So so it's no surprise also that more women and children in lower income countries are dying from disruptions in the health system because they're the most vulnerable. And when a community is affected in one setting, it's actually the vulnerable, such as women and children, who are affected. So when we say engaging communities, at least at CARE, we consider communities and as living organisms. Within that community, there are individuals who are key influencers. So there's very important to identify who those key influencers are and work with them. So whether it is a pastor or an imam or a clan leader or a local government official or a chief, there are individuals in the community who are influencers. And secondly, we have a tool that we use called the community scorecard that we piloted in Malawi. This community scorecard involves individuals who gather together with the health system folks and sit down together and identify what the issues are, what is going on at the health center that is not serving the community. So once they identify what that issue is, they work together in a mutual accountability way to figure out how can we resolve this issue. Standing in line for 10 hours, going to the lab and not finding certain reagents, going for your HIV medications and they're out of stock. So how can we work with you as a community and put pressure not only on you as a health system to hold you accountable, but how can we help you, the health system, to put pressure on the government, whether local government or national government, to ensure that these bottlenecks are opened up. And then lastly, when it comes to especially COVID-19, engagement means that we work with the community to understand culturally, historically, in terms of the key influences, who is it giving you the misinformation and disinformation? And once you identify what those things are, you work with the community to say and understand from them what is it that they would want to change in order to get the right information, decrease hesitancy for the vaccine, and increase their confidence. Thank you.
That's great. I love the community participation approach from the beginning. I think that's terrific. And I always love to hear anyone in development say mutual accountability. So that's great. I just want to pick up, though, I mean, we're talking right now and we are the Global Health Council. So obviously this is about health. But Jen, you said something earlier about economic impacts of COVID. And we heard earlier in one of the concurrent sessions from one of our panelists who was talking about the impact in conflict settings about the issue around livelihoods and what COVID has meant for livelihoods, particularly in the informal sector, and how that kind of, maximizes the disease trajectory, right? That people lose their income, they don't have food, that become more susceptible. So I'm wondering too, on the community engagement piece, if we could just talk a little bit about this livelihoods component and even the gender dynamic of that. And I know this question was not in the prep, so I'm just throwing it out there to anyone that wants to dive in further on that piece, because I think there's so many other impacts of COVID and this lack of resiliency in health systems that it's not just health in itself. And it's really important for us as a community to recognize it and work on fixing that as well. Anybody want to jump in? Irene?
Oh, yeah, I'll try, and hopefully my mic is working. So you'll tell me.
Yes, it is. We can hear you much better.
Okay.
Thank you.
So, I mean, COVID absolutely, to your point, it's had a huge impact on livelihood. And I'd say, maybe talking about two of the main areas. One is on basic food security for families, right? Their access to food is huge. It's needed in this country, but it is a global issue. And the issues of hunger in more countries and even burgeoning famine in a number of countries, not just because of COVID, but also because of things like climate change and conflict are it's a devastating issue around the world, and the likes of which we've not seen since the last World War. The other issue is really on adolescent girls. Adolescent girls have been made incredibly vulnerable because of COVID shutdowns, because of the increased inequity in livelihoods. The girls are out of school, which means they're much, much, much more vulnerable to sexual violence, to early pregnancy, to unwanted pregnancy, early marriage. And they are in so many countries not going back to school even as schools reopen. I mean, this is a huge vulnerability and a huge issue that we really, really need to pay a lot of attention to and take on across the board.
Thanks. Jen, did you want to?
I'll just add one thing. We know from analysis the World Bank has done that there are millions more people living in poverty now because of COVID. And that, again, is going to be a problem we're going to have to address for years. And one of the other pieces of data that I think is just important to look at, I mean, just knowing what happened in the United States, the amount of budgetary support that has been provided to help individuals, families, and firms really is incredibly varied. It kind of if you look at that map, it's the same as the vaccine distribution map. So rich countries have a lot more budgetary support to help families, in this time, and it's still been a struggle for people in the United States and elsewhere. And countries that have limited access to vaccines actually got very little budgetary support from their governments because their governments don't have that support to provide. So, that's a structural challenge that we're going to have to, I think, as a global community, find a way to address because it's so connected to health care and health outcomes. Over.
Dr. Wakuya and then Tom.
Yes, I think if there's one major devastating impact of COVID-19 has been the gender impact, especially the impact on girls and women. My own home country, Uganda, which I love dearly, has had the terrible record of being the one country where children have been kept out of school for the longest. It's the number one country in the world where it is 77 weeks and counting that children have been out of school. And they're heading back in January. But the number of teenage pregnancies has been astronomical, not only in Uganda, but in other countries. And also gender-based violence, in terms of the domestic violence cases that have gone up. The impact on livelihoods on girls and women who are oftentimes the market vendors, and that is their only economic livelihood. And with the lockdowns, that has affected them, let alone maternal mortality going up as a result of the fact that lockdowns do not help a mother go to a clinic because she cannot stop her baby from being delivered. And we have had horrendous stories where women are stopped at a checkpoint when she's in labor going to a clinic, and it's a lockdown, it's a curfew, and you cannot go to the clinic, and the woman delivers on the road. So the gender impacts have been absolutely devastating. And we do need, as an advocacy community, to work with governments to figure out the laws and the policies that can protect girls and women, and especially now that many are opening up again, bring back girls and women into the educational ecosystem in a very compassionate and tangible way. Thank you.
Thank you. Go ahead, Tom.
Just briefly, I wanted to offer a couple of things that we're working on to address the economic fallout. On this panel are 3 groups that are very, very important to that. So I want to acknowledge that up front. A couple of things that we're working on in addition are this, and it's not getting much airtime and probably shouldn't because it's so hard to explain, but the IMF did an historic large allocation of what they call SDRs. It's their IMF currency. It's really a basket of major currencies. 650 billion they issued. Now they issue them in proportion to the shares of the IMF. So wealthy countries like the United States got the largest share, poorer countries got far less. We are now in a campaign to reallocate from wealthy countries that don't need that relief, those SDRs, to the poorer countries with a goal of reaching 100 billion in these SDRs for the poorest countries for exactly what we're talking about: food security, helping schools, giving that fiscal space. We're about 50% of the way there. About 50 billion of these SDRs have been reallocated. We're looking for the US to do that. It's in legislation right now. So we're hopeful. Another is the World Bank's IDA program, which is having its replenishment conference this week, maybe even today. I've forgotten exactly what day it's when exactly happening. And it's just one of those incredibly important pieces of the puzzle as you look at the different spigots of resources to help address the incredibly important issues that have been raised here. I wanted to highlight those 2.
Great. Thank you so much. So we've talked about communities, and I want to switch gears a little bit. I mean, from what all of you have said, communities are in trouble in many ways across the world. I mean, whether it's the US or in any other country because of this pandemic, but particularly in already low resource settings, it's a problem. At the same time, we hear quite a bit of conversation about the need for localization in global health. And I want to unpack that with everyone a little bit. First, to just talk about what's the difference between community engagement and localization, but then also to put this in the context of global health security. If there is a need for localization in global health, what does that mean for global health security, and what are the implications for that? Not just for COVID, but for other goals: maternal child health survival, malnutrition, other contraception access, a lot of the things we've talked about. Irene, I'm going to start with you, and then I'd welcome other folks to join in.
Yeah, no, thanks, Alicia. It's a great question. So localization, is about putting resources and putting in the driver's seat local partners, whether that be local civil society, local NGOs, local governments, right? As opposed to those of us who live here in Washington or in London or wherever. But really, it's putting the resources and the power in the hands. And it is very connected to communities because invariably it's the local CSOs and local NGOs who are part of those communities and have the relationships. And it's an incredibly important and powerful force if we think about what has to happen for global health security, right? Because it is those communities who are the ones that are first going to see when there's an outbreak, right? It's the community health workers, it's the local NGOs who will see that something's going wrong. It's in connecting those people and those organizations to the public health system is extraordinarily important. They're also very, very connected to primary health care. And we haven't talked too much about this, but primary health care as part of how we look at global health security is really important. We've traditionally, global health security has been much more about the tracking the pathogens and diagnosing and responding to the pathogens. But if you don't have that primary healthcare system in place and functional, as we talked earlier, and to Julie's point, it doesn't really matter, right? And then lastly, one of the things that is so important in any part of global health security, in any response, whether it be to a measles outbreak or COVID or Zika or Ebola, is around addressing misinformation and stigma and discrimination and rumor, et cetera, right? And rumors and misinformation can spread as fast as the pathogens themselves. And it's where local NGOs, civil society, community groups are extraordinarily important and powerful forces in trying to mitigate and get the right information out. They're often the ones who are trusted by individuals, and whether in a community, in a neighborhood, in a group, whatever kinds of group there are. And that's where, we Save the Children, we do an awful lot of work in social behavior change and risk communication for around vaccine and everything else. And exactly as Dr. Angela was describing, working in partnership with those local community groups, local civil society, NGOs is core part of what you need to do, because it is the trusted influencers, exactly as Dr. Angela said.
So I'm Julie. Did you want to say something? And then
sorry, I was trying to turn it to you first, Dr. Wakuya, and then to Julie. But of course, I was muted, just talking to myself. So go ahead.
Sure. Let me jump in, and then Julie, I absolutely would love to hear your thoughts as well, because what we welcome so much as a global public health community is the fact that USAID has put out, a missive that we should invest more in local civil society organizations. This also happened way back when PEPFAR was announced. As time went on, PEPFAR put in place a policy of 70% of the funding that is received by any bidder of USAID funds for PEPFAR-related efforts needs to go to local civil society organizations. I think that's also a trend that is happening and will happen with COVID-19. The reason why that is important, much as like Irini said, these are organizations that know what's happening on the ground and live and breathe with the communities that we talk about, or want to engage or want to improve their health. There is no viable economy, government system, thriving community without a viable civil society. The US and other countries in the global north have nonprofits who come alongside government to deliver services. So local civil societies organizations are absolutely critical to any effort. And you asked the question, Elisha, the difference between community engagement and localization. They oftentimes are used together, but actually they're quite different. And community engagement can be anything related to listening to a community, because we don't do enough of that. Listening to what the community is stating as their need, never coming in as top down that what, but listening to a community, making assessments, figuring out what the situation is, and making your responses that meet the needs of a community. With localization, there's a major movement globally that we need to go local, and localization is a way to make things sustainable and viable and appreciated and also understood by a community that they played a role in their own health. And local civil society organizations, whether they're faith-based organizations, community-based organizations, local non-governmental organizations, are going to be absolutely critical to the work that we do in the future. Over.
Thank you. Thank you. Music to my ears that there's no viable government without viable civil society. So I'm sure those of you who know me know that's sort of like my catchphrase. Julie, did you want to jump in here?
Yeah, I'll just add a little something. I think the question about localization and the movement towards shifting that locus of power is important, and also calls into question what is the role of international organizations in the future. Are we working ourselves out of a job? I think that there probably is, a long period of time in which certain organizations are going to continue to need technical assistance. But are we really the ones best placed to provide that? And we've been talking and thinking about, is there another level of local and regional organizations that have the capacity to become the technical assistance providers? And then what is our role? Well, maybe our role early on is doing that coaching and supporting and sharing across countries and learning and that sort of thing. But it's true that eventually we do want to work ourselves out of a job. And I think that, that is something that the global health community is going to need to reckon with. It might take some time. I think a lot of donors aren't yet entirely comfortable that very many local organizations can adequately steward their resources. And it may take time to build the capacity of a wider variety of organizations to be able to do that. But we really need to think about the future role of these international organizations and, start planning for that change. So I just wanted to add that.
That's a great point. And actually an excellent segue into my question for Jen, particularly as it relates to global health security. We've talked about health systems, we've talked about communities, we've talked about donor funding, all in kind of the health milieu, right? So, I mean, again, Jen, is that enough? Should we only be focused on health? And is health security and frankly, health equity only the responsibility of these health groups or cohorts? Or is there something else, other avenues? We've heard, rumbles of defense authorization around the pandemic and bringing in DOD from the United States. Is that a good idea, bad idea? What are the implications?
Great. So I wish I could say I'm going to answer exactly your question, but before I do, I neglected to say something earlier. You asked, we're looking at opportunities, and you asked about the nominee for the PEPFAR coordinator. I just want to say Dr. John Nkengasong, who is currently the director of the Africa CDC, who is the nominee. All of the issues we're talking about, he is living them. So I think the opportunity there is somebody who is, experiencing all of the challenges and the opportunities that we have before us. So I think bringing him on would be a real plus for all of us in this work. But to your question, I'm going to start with a quote. So just bear with me for a second. So here's the quote. Our new security agenda should be pursued with determination, adequate resources, and creative use of the new tools at the world's disposal that can be used to bring us together in successful common efforts, which, if used imaginatively, will enable new depths of insight and cooperation by nations, non-governmental organizations, and citizens at all levels. All this and more constitutes the great global challenge of our time, to create and strengthen a sense of solidarity as we seek a newer world of security for all. Now, if we had more time, I would quiz all of you to see if you know who this is and when it's from, but we don't, so I will tell you. This is former Vice President Al Gore speaking to the UN Security Council on January 10th, 2000, at what was the first meeting of the Security Council in the 21st century, and the first time that the Security Council discussed a health issue as a security threat, which was HIV, of course. So I just say that because history is important, and I read it in preparation for our discussion today, and I have 3 questions that I'm going to pose back, and I'll just share some thoughts on them, and then I'll stop. The first is, and I think it's to answer your question, will this time be different? Are we truly at a new place in the dialogue and action about global health security than we were in 2000? 2, and related, will this lead to an end to the episodic funding cycles that we have experienced that leave us at best flat-footed when the next crisis hits, and at worst already treading water? 3, whose responsibility is it anyway? Will new avenues truly be explored, such as defense? So I think on the first point, will this be different? I don't want to belabor that because we've been talking about this. I think there has been a shift since 2000. We are not in the same place. To me, the question is how indelible is that shift to fundamentally change the equation? And hopefully in 20 years from now, the words that are written are not the ones from 2000, but they really are about the solidarity that we have achieved to get there. Second, on the question of will we finally get out of this episodic funding cycle? I can't answer that yet. I think that will be, we'll come back for next year's GHC symposium and maybe we'll have an answer. And then finally, on this issue of whose responsibility is it, and the Defense Department in particular, it's not new that the Department of Defense has been involved in international health. There's a long history there that we've written about, others have written about, and certainly in a more narrow sense, involving the military is not new in how we respond to crises such as Ebola and others. But I think what may be new now and a new opportunity is that there seems to be a shift from saying that because there's such a recognition of the global threat of any kind of crisis or a pandemic that COVID shows us, that it's not just about donor nations helping others through development assistance. This isn't just about charity. It's about protecting everyone, everywhere, an insurance policy for the world. So there may be some more appetite to explore this. one that goes beyond the traditional development assistance envelope to potentially what we think of traditionally as the defense budget. There may be some traction there. It's quite delicate. I don't know if it's certain, but I think it's something that I have, in my years working on this issue, have not really seen us at this point where that's actually part of the discussion. So that says to me that there may be a shift there that needs more thought. As I said, I think it's delicate. So I'll stop there. That's the end of my history lesson.
Thanks, Jen. Does anyone want to weigh in on this question of kind of whose responsibility is it? If not, I can turn to the audience because we have a few questions in the chat. Dr. Wakuya.
I'll just jump in that it is primarily the responsibility of national governments to take care of the people within their borders. But it is the responsibility of all of us as a global community to take care of one another. And then lastly, I would say the ground shift that is happening is that over the last 2 to 3 decades, local civil society organizations in these countries where governments sometimes are failing to take care of their citizens are growing and are stronger and they have very strong advocacy voices. They're talking in the media, they're challenging government. So local civil society organizations are going to shift the paradigm where I see some positive fruits that in the near future, things will turn out for the better.
Okay, go ahead, Irene.
Like, just on one quick comment on certainly on Jen's history lesson. I was thinking you were going to tell us it was Winston Churchill or FDR, but so far better than
probably could find that.
Sure we could. But and going back to your first question, is it different? It feels like we had a similar conversation.
Oh, Irene, you're cutting out again.
Sorry, we had a similar conversation after the West Africa Ebola outbreak and whether or not, now is now the time to focus on health systems or not, right? So, but it does feel, and I agree with Jen, I think there is an increasing shift, and maybe it's 2 steps forward, 1 back as we go through each one of these crises, and hopefully moving forward, that there is a change. And then on that point, going back to Julie's point, and I very much agree with Julie, whether it's working ourselves out of a job or changing the job of the traditional, Western-based organizations, it absolutely is going to be a different job. And to Dr. Angela's point about local civil society being an extraordinarily important, powerful place, not only for reaching those who need to be reached with health services, but in making the case for local action and local investments, in addition to those from rich governments.
Thank you. Why don't we take a few questions from the audience, and then I'll come back to the panel for some closing words, tangible actions that we can do, or moments we can engage in. We have one question here from Michelle Farmer. How can community systems support data collection and program monitoring? Community health workers can be vital contributors, but we need to empower them as part of the data monitoring for continuous quality improvement and for community emergency preparedness. That's a great question, and I think goes back to some of the earlier discussion of leveraging existing health systems, and also this kind of like, we don't just need the treating in the moment, but we need some predictability and diagnostic tools. Does anyone want to take a first stab at this question?
Sure, I'll take a stab at it, given the conversation around community earlier. Within a major flagship program of ours, in the Bihar state of India, we have found that indeed, as Michelle asked in her question, that frontline health workers, who are often even the informal, unpaid, non-clinical frontline health workers, who are called, community health workers, they're called community health extension workers, they have different names in different countries, they are key to the data monitoring and evaluation of what's happening in a community. If we empower them, many of them are women, of course, if we can empower them with a stipend, some kind of remuneration, support to, many of them are women, childcare, if we can support them with the tools such as a phone that has an app that is able to take in some minimum information, demographics, and other issues that the community is dealing with. We did this in Bihar, over a 10-year program that was funded by the Gates Foundation, and have proven that empowering the frontline health workers to bring this data back, not only physically, but also through their various applications, that they are able to show that maternal mortality can go down, childhood mortality, neonatal mortality can go down. So it is possible. That's a great question, Michelle.
Anybody else? Julie.
I'll just add in that, you know, I think we're still dealing with, in many contexts, the, you know, unpaid or poorly paid community health worker, where program after program comes in and imposes yet another thing they want them to do. And if we don't start supporting, paying, and continuing to professionalize community health workers and integrating them with the health system and supervision systems and the like, they aren't going to be able to, you know, to collect data that's useful, or they're going to spend all of their time collecting data. So I think there just needs to be a lot more cooperation, collaboration in terms of determining their roles and responsibilities.
Thank you. Yeah, my eternal question is, why can't we get the community health workers paid? Like, I still don't understand that. There was a question earlier, and I'm not sure where it is on the screen, so I'll just read it. But Irene, you had mentioned misinformation before, and that there's lots of channels circulating with, you know, things to sort of keep people from the health system or keep them from wanting to get vaccinated. What about this information, which is good, solid information, data, and evidence? How do we better share that and get it disseminated, not just to us, because I know we get a lot of it disseminated to us, but how do we get it to those groups that we've talked about today? People accessing the primary healthcare system, community health workers, marginalized communities. What's the best vehicle? Because I think we are falling short on the infodemic, right? That's the information wars. So I would love to just have anyone weigh in on that piece. I'm going to start calling on people.
Yeah, you know, there's not an easy answer to this, but you're right. It is, because there's so much information out there. We've talked some about you know, I think earlier about the use of the digital channels we have. So making sure there's information not only pulling up from those at you know, community health workers and others, but also information coming back down. And as we all know, information is better when people use it and have access to something they can use. So looking at, you know, it's that two-way communication, which is also a core, you know, certain, as we talk about behavior change and risk communication, it is listening to what people need to know and what their concerns are and feeding it back to them and sharing the right information, that two-way communication, as well as looking for ways to share it back up and down and across the system is hugely important. But there's not one simple way to do it. It's just, I think, the bottom line.
Tom, can I actually ask you this question as well, since one has a huge grassroots network, and obviously you have a kind of masterful communications team that does a lot to bring people who maybe aren't technically versed in poverty eradication or health systems into the fold and really get them fired up about it. So if you wanted to share what your secret is, maybe we can parlay that into something for the rest of the world.
Oh, wow. That's a tall order. And it's not going super well, by the way. Has anyone noticed that? Yeah, no, I mean, our advocates are as fired up now as they've ever been. I mean, look, simple formula for getting folks involved, which is talk to people like they're not policy experts, related to themselves, keep it simple, have a direct call to action, meet them where they are, not where you hope they will be, which are sort of basics of influence, whomever you're talking to. But of course, we also have to rely on innovative ways and of communication, different channels, whether that's social or disaggregated media, and also different spokespeople. I work for a very high profile spokesperson, and I'm constantly saying, actually, it shouldn't be you, it should be someone else. or think about who your audience is and who is going to resonate. So just a couple of thoughts.
Yeah, no, I think that that's great. I think that there's a lot in there, especially about speak to people like they're not policymakers or technical experts, which I think is what we tend to do because that's what we know, right? But really finding what resonates with others is the key to getting them to listen to you. And who delivers that message is also important. I want to ask one more question from the audience. There's a lot of interest in here again about how we leverage existing structures and lessons learned from the vertical programming that we have now to tackle COVID. For those of you who have worked on or do work on kind of the vertical, disease sector programs, are there any lessons learned that we can use to tackle COVID and support health system strengthening? Are any specific examples of what you've seen has been a good way to do that? Jen, you look like you want to unmute yourself.
Sure. I'm not an implementer organization, so I'd be really curious to hear from some of the implementers. But I mean, there are just so many examples, and part of it is, my knowledge or experience is really with PEPFAR and the Global Fund, and both of those are, in a sense, they're not new institutions anymore, but I watched them as they were born and grew up, and so some of it is learning over time. But a couple elements I'll just highlight. One thing that has, I think, really enhanced PEPFAR's ability to have reach and to also strengthen local systems is I think among bilateral programs, it's fairly unique in how it involves community. I think anyone in the community would say it's not enough, but if you think about it, I'm not really aware of another bilateral effort, HIV or otherwise, that actually asks for the community to provide feedback on the guidance that goes to the field, and then actually revises that guidance so that it reflects some of the community input. And then the community itself is involved in the country operating plan development. Again, it's not a perfect system, but to me, that's a way in which PEPFAR has really evolved, often because advocates pushed it to do so, but to include community in a very meaningful way for a bilateral program. On the Global Fund side, I think one analogous example, although it's different, is that the Global Fund actually includes community in its governance as a formal part of the governance of the Global Fund, with a vote equal to any vote on, and not just a community vote, but there's a developing country NGO vote, a developed country NGO vote, there's implementer votes. That is a formal way to make sure that the decision making and the way in which these vertical programs are designed and implemented and monitored have voice in them. So we didn't talk about that so much, but I think those are important lessons. And the other is that both, and I think they haven't led this per se, I think they're partially reflecting and now leading on it, both have adopted an equity lens on the work that they're doing. Particularly if you look at PEPFAR's new strategy principles and its COP guidance, equity is a new focus. And part that doesn't necessarily translate into achieving it, but it's certainly a first step is to have it in there. So I'll stop there. Thanks.
That's great. Julie, over to you.
Yeah, I think I'm going to push back a little bit on the question, maybe not entirely, but yes, I do think vertical programs can do something, but I think for the most part, when they do attempt health system strengthening, it's pieces of the health system. And we don't have a funding stream for comprehensive holistic health system strengthening, and we need to have that. We used to always say prevention has no lobby. So, there aren't, people with breast cancer or HIV who strongly advocate for the disease. Prevention doesn't have that lobby, and health system strengthening doesn't have that lobby. So I pose again, how can we convince donors that health system strengthening in a holistic way are worth investing in and are an incredibly important part of pandemic preparedness?
Thank you. Anybody else on this one?
Oh, I have to echo that one, Julie. You took the words out of my mouth. If there's anything that can bring these vertical programs together, it's health system strengthening, because from the bricks and mortar to the people, the frontline health workers, to the supplies and the whole 9 yards when it comes to health system strengthening. That is the undergirding of integrating the vertical programs in ways in which they can be a holistic approach to both prevention and care of persons dealing with a whole host of things. Because the mother who is potentially infected with COVID-19 is the same mother who is a mother of, about 7 kids at home, and who may or may not be fully immunized, and she may need antenatal care and obstetric care at some point. So I can only applaud what Julie said, that there needs to be a funding stream for health system strengthening. And I think that's why the global community is talking about it more, and USAID, and even Rochelle Walensky in her initial remarks talked about health system strengthening as a major piece of foundation to global health security going forward.
Thank you. So we have a few minutes left here, and I want us to turn to tangibility. I have a kind of a big question around that I'm going to ask everyone. But first, I'd actually like to ask Tom, if you could just run through some moments that are coming up in 2022. There's a lot. I'll stop there. And this is really from a U.S. policy lens primarily. There's some multilateral component. I'm sure for all of you in the audience from different countries, you have an equally long list. So we're going to stick right now with this view. But if there are other things you want to put in the comments, please do.
Well, because this is the Global Health Council Symposium, stepping back and looking at what's coming at us next year, I hope we all get a good holiday break, because it's a doozy. I think the trajectory of U.S. global health policy will be set for the next 5 or 10 years next year. So I know very little about what's going to happen, but I know 5 things. PEPFAR needs to be reauthorized. It expires next year. And that's not, we always equate this with HIV/AIDS, but actually the bill authorizes programs for AIDS, TB, and malaria, as well as our participation in the Global Fund. So that's going to happen. The United States just announced that it's hosting the Global Fund replenishment sometime Q4 of next year for the next, and that will dictate funding globally for the Global Fund for 3 years. There will be action on pandemic preparedness or global health security authorization legislation. There is legislation in both the House and Senate, bipartisan, and we expect that to move. We will continue to have global COVID response. I mentioned the Biden summit, the G7, that will remain. Hopefully there'll be supplemental funding considered by the Congress. And fifth, normal budget and appropriations, for child survival, for nutrition, for, women and girls, all that has to be dealt with, will be dealt with next year. So this is a conversation among experts in implementation and policy. I hope we all take a break from the holidays and come back as advocates, because those things will happen, and they will either happen well or they will not happen well. So I'm really appealing to all of us to get ready to work hard on this, because it's really going to be super, super important.
Thank you. Yes, take a break and come back as advocates. I love that. I'm also going to change your name to Mr. Sunshine, because you just listed out so many things that are so important that need to be done well, exactly as you said. And there's a lot of work ahead of us. So I want to go into closing statements here, and I hope that for your comments, you'll really think about this frame. We're coming to the end of 2021, obviously, which from my view flew by in a way that 2020 did not. I think we all thought we would be having this meeting in person, that we would be traveling, that we would be far out of the pandemic, as opposed to where we are right now. And we're going into 2022 not having achieved global health security, and certainly not having achieved health equity. I hope that we do achieve global health security like the first day of 2022, but I don't think that's going to happen. But certainly by the end of 2022, we are out of the pandemic worldwide, not just in high-income countries. We're probably not going to achieve health equity by the end of 2022. But hearing the list that Tom just said and all the other things happening, I'd love to hear from each of you one tangible step we should be taking in 2022 to make progress on health equity? And who would like to start? Dr. Wakuya?
Sure. One tangible step towards health equity. As I mentioned, my biggest passion in the next decade, at least of my life, of my professional life, is going to be dedicated to supporting frontline health workers. When it comes to health equity, the person who touches that girl and that woman in that village or in that urban slum or in that displaced community or in that refugee camp is going to be likely somebody who lives in their community, knows that community, speaks to that girl and woman in ways in which none of us, even I who originally came from Uganda, but I live in the global north, cannot even begin to comprehend her needs. And the frontline health worker over the next year and decade and 2 decades is going to be absolutely critical, supporting her, and it's mainly her, that supporting her, remunerating her, providing her with the tools such that she can help that girl and that woman especially, but the vulnerable member of the community, touch the primary healthcare system. Thank you.
Great, thank you. Support frontline health workers. Great. Julie?
Okay, I am going to mention that one way to improve equity is through stronger health markets and integration of the private sector. Now, I know that we don't usually talk about equity in the private sector in a single breath, but I do think this is really important because a large proportion of healthcare in many different countries is provided by the private sector, including for the poor. And people choose the private sector because it's often closer, easier to access. People might perceive the quality to be better because they have a better client experience. But in order to do this in a way that enables the private sector to sustainably serve the poor and increase coverage and increase equity, we need to work to improve quality of care in the private sector. We have to increase access to financing and supplies, affordable supplies. We need to create more integrated information systems so we know where the private sector is and who they're serving. And we need to develop supportive regulatory and policy environments. And so when you link some of these things, like, for example, linking financing, strategic purchasing, or access to capital to quality conditions, it can be a powerful incentive for the private sector to get there and improve that quality and help improve that equity. So all of this to say that I think it is possible to create an enabling environment for the private sector to function better and to improve affordability of care and to increase equity and access.
Thank you, Julie. Appreciate that. Jen, I'm going over to you.
Sure, yeah. This is a tough one about what the concrete steps are, but I was thinking over the last almost 2 years, myself and a lot of my colleagues at KFF have spent an incredible amount of time looking at the domestic COVID-19 response in the United States and highlighting the inequitable impact, both of COVID and then everything else. So whether it's tests, vaccines, access to services, people who are underserved, racial and ethnic minorities in the United States, poorer people have just suffered much, much more. So one of the ways we've tried to address that is by highlighting that and continuing to highlight that impact. I think globally, what I hope for in the dialogue in 2022 is that we, in addition to continuing to talk about global equity, meaning the differences between countries, we start to get a little bit more, it's more complex, but as important, talk about equity within countries. Because we know that even as vaccines get into countries eventually later than they need to, or diagnostics or other things, it's not going to get to everybody who needs it. And women and girls and certain healthcare workers and others are not going to get those life-saving interventions. So For me, part of it is changing the discussion about equity to include equity within and who we're trying to reach, not just equity across countries. Thanks.
That's great, Jen. Thank you. And I know we've raised that before in equity between rural and urban access, girls and women, as you mentioned, but I think you're right. We're so focused on the big inequity that we haven't been able to get granular. Irene.
Great, thanks. Just building on Jen's point, the COVID has really put a spotlight on inequity in healthcare, which has been in access to health, which has been something we've been talking about in global health for a really long time. But the practical next step, from my perspective, is really digging down on the visibility. Who really are those kids who are the zero-dose kids who are not getting any access to vaccine, which also means they don't really have any access to anything else. Who are they? How best to reach them? Where can we engage what civil society, what local governments, what groups are best placed to reach those people who don't have access, whether it be a financial limitation, discrimination. There's all kinds of reasons there's inequity in healthcare, but really we can't address it unless we have a much better sense of what it is. So taking a practical application to the visibility in the data would be a potential way to make some progress on this long-standing issue.
That's great. And I think it ties well with what Jen said of really like, who is it that we're talking about and how do we get to them? That's really important. Tom, last word to you on this question.
I'll be very brief if you'll afford me to. My first goes with my last comment, which is that everyone needs to write their representatives in Congress. That is going to be the single most important thing we could do to get toward global health equity next year, because so much is happening and it will be shaped either well or poorly, as I said. The other is everybody listening should write a check to the Global Health Council. I didn't. I'll send you my.
Now you really are Mr. Sunshine.
Send you my bill later. No. You didn't set me up to say that. But seriously, we really we need to keep together. Global Health Council provides an incredible platform for those voices together, and it's been such a strong and articulate voice in equity. And I'm really grateful to you all.
Thank you so much. We appreciate that. Okay, we're a wrap, people. Thank you so much, panelists, for this excellent session. And I love that you actually did give tangible, concrete steps. Support frontline health workers, write your representatives, talk about the big inequity and the small inequity, visibility of data, people, who's missing out from the health system, and integrate the private sector. All terrific things to work on in 2022. Thank you so much. We really appreciate you taking the time to be panelists and look forward to working with all of you.
Thanks, Alicia.
Thanks.
Thank you. Bye.
Thank you, Alicia.
Okay, so I'm going to stay on stage for just a couple of seconds or minutes, actually, and just say a big thank you to everyone who came to this symposium and made it such an amazing discussion of good ideas. It was inclusive, it was vibrant, you were all so engaged, and we so deeply appreciate that. And of course, a big shout out again to the Global Health Council team and the staff that really made all of this happen, and to all of the member organizations that helped us develop these great panels and sessions, and to all of our participants throughout the world, particularly those who were doing their panel sessions at 1:30 a.m. or other times that were not convenient to the Eastern Coast time. We appreciate that so greatly. We will be making videos of all of the sessions available on our website. Give us just a little bit of time to get those uploaded, probably sometime next week. But we will send around an email blast to let you know that those are up and available. And if you need anything from the Global Health Council team, if you want to join as a member, if you weren't already a member, we welcome that. If you want to work with us on all of these big things that we need to accomplish in 2022, we also welcome that. And so really heartfelt thanks from all of us. To all our sponsors, thank you. To all the participants, thank you. And to the GHC staff, thank you very much. Have a great weekend. Go get some rest. And as Tom said, take a break and come back as an advocate. Thanks so much. Bye-bye.